Good afternoon, everyone. Thanks to the organizing committee for the invitation. As you see, I'm all wired up, but I'm not going to sing here, so don't worry. I'm just going to speak. So I'm going to talk about guidelines, does cost matter, and throughout my presentation, I will refer how Colombia undertook a pathway to introduce economic evaluation as piggybacks of the clinical practice guidelines since the beginning of the HTA agency. I will start just by saying that we all know that all health systems face the challenge of managing finite resources to allocate services and healthcare for the entire population. And as was mentioned before, it doesn't matter if you live in a high-income country or a low middle-income country. Potentially, there are infinite needs and limited resources. And on top of this, every year, the costs of healthcare increase and suffer from inflation that most of the time goes beyond the cost of any other sectors within the economy. So there is need to set priorities, and we can stress or we can say that probably we have to look at the costs and constraints as an argument to set priorities. From the clinical standpoint, we also know that clinical care many times departs from best practice. We tend to be inefficient either because we fastly adopt technologies without certainty about the clinical effectiveness or cost effectiveness, but in many other cases, we tend to adopt very slowly. So again, we might stress that there is no need to set priorities, but in this case, thinking about the quality and efficiency as an argument to prioritize. Whenever thinking about producing clinical practice guidelines or guidance, it is important then to balance costs and constraints versus efficiency and quality, and actually all those things were the things that were taken into consideration when we were establishing the HTA agency in Colombia. Colombia, as you can see, is that orange spot on the northern part of Latin America or South America. Is a country is an upper middle income country with around 50 million inhabitants that in 1993 underwent a major health sector reform that entitled access to the entire population through statutory health insurance. The benefits package established at the very beginning was inequitable for those in the subsidiary regime and for those formally employed in the contributory regime. And although the country has marched towards UHC in recent years and currently covers around 98% of the population, it has faced many challenges. The country invests only around 7% of its GDP in health, and the benefits package has been challenging or is challenged very frequently by judiciary claims, something that we call tutelas, from the citizens asking for health care coverage that was not initially budgeted for. This phenomenon is worth mentioning is not something unique to Colombia. In other parts of the world like Brazil, Argentina, Costa Rica, Uruguay, South Africa, judicialization of healthcare has become a huge burden to the health systems because of lack of legitimacy, transparency, or systematic priority setting. In Colombia, there is an estimation of around 120,000 requests via judicial claims, which means something like 1 every 5 minutes that challenge coverage via this mechanism. The benefits package has been expanded, is more systematically updated, but after 2009, the system has been experiencing financial strain and is submerged into a financial crisis that was initially estimated in around 2 billion Colombian pesos, and more recent figures estimate something around 10 billion pesos, Colombian pesos. This intricate graph tries to make a long story short and basically shows the policy process of establishing a health technology assessment in a country like Colombia and how evidence-based or the interest in evidence-based medicine got into the policy agenda. Although many attempts were made before 2008, only after inflationary costs, the need to advance towards UAC, the heavy judicially requests of the population led to the enactment of national guidelines for clinical practice guidelines in 2008. And as you can see, those two stars there, those mean the windows of opportunity for policy action, and actually it was in 2012 when the HTA agency was established. After that, Colombia embarked in an endeavor of producing clinical practice guidelines. Most of our guidelines stick to what are considered to be good practice. They use GRADE, AGREE, AMSTAR, and in 2014, a reference case was updated using economic evaluation, most of the time going for cost effectiveness analysis, and was introduced as part of the clinical practice manual. Currently, the country has developed around 60 clinical practice guidelines, either directly by the institution or by collaboration centers. Due to limited resources, not all the key or PICO questions are then, or recommendations are then translated into economic evaluations. Using GRADE, the top 1 or 2 recommendations are then converted into economic evaluations, as I said before, most of the time using natural units, cost effectiveness analysis, aimed at portraying the opportunity cost of key recommendations and supported by budget impact implications. So in our case, we truly believe that costs matter, and the use of health technology assessment and budget impact analysis alongside clinical practice guidelines are key to informing recommendations. In Colombia, clinical practice guidelines and HTA emerged after a converging interest about a decade ago from academics and the government on using EBM methods. There is a national methods guideline for producing clinical practice guidelines that was firstly released in 2008 and updated in 2014. That has a reference case informing cost effectiveness and cost utility analysis. We believe that besides quality of healthcare and cost, there is also an opportunity to consider social accountability as a need to be more systematic when setting priorities and issuing recommendations. And one key example is the case of tutelas or judicialization of healthcare. If patients, populations, decision makers, they do not trust recommendations or the way priorities are set, of course they're going to challenge coverage. The HTA agency, IETS, is among the 250 organizations devoted to developing clinical practice guidelines, and the institution is among the 68 centers that incorporate health technology assessment and budget impact analysis within clinical practice guidelines. We think that HTA and budget impact analysis are part of, along clinical practice guidelines, bring the opportunity of showing the opportunity cost and raising awareness not only on prescribers, patients and carers and payers, but also on something that we call intermediate prescribers, which are the judges. In Colombia, a judge kind of acts like a doctor. They can say yes or no to a prescribed medicine by a patient, by a physician. Of course, costs matter, but I believe that not only costs matter regarding recommendations, but also the cost of developing robust guidelines. I think that not only in high-income countries, there is fragmented funding for clinical practice guidelines, but especially in low and middle-income countries, that those sources of funding have been stagnated over time. There is fragmentation, and even if you kind of commit to this endeavor of producing 60 clinical practice guidelines, many times you don't have enough money to update those guidelines 2, 3, 4, 5 years after. So, of course, costs matter, and I think it's not only about recommendations taking into consideration costs, but also the cost of producing clinical practice guidelines. Thanks very much.